Hi, I'm Sabrina Manwiller,
And I'm Kristen Howergy.
and we are midwifery students at the University of Colorado Anschutz Medical Campus. And this is our Pecha Kucha presentation on twin-to-twin transfusion syndrome. This is in partial completion of our Nursing 6352, Care of the High-Risk Pregnancy. Twin pregnancies are usually characterized by their placental and amniotic characteristics. The placenta is referred to as the chorion, and the sacra on the baby is the amnion. About 80% of twin pregnancies are dichorionic, meaning they have two placentas, and the remaining 20% are monochorionic, where there is one placenta. Of monochorionic twin pregnancies, 10 to 20% will develop twin-to-twin transfusion syndrome. This disease results from an abnormal bridge in the circulation of the placenta that connects the umbilical cords and the circulation of the twin fetuses. This imbalance in circulation means that one fetus gets more blood and nutrients than the other. There are several theories as to why twin-to-twin transfusion syndrome occurs, but the exact cause is unknown. One hypothesis is that around the 5th week of gestation, the venous and arterial connections are being established. These vessels create overlapping boundaries forming various anastomotic connections, which are separate parts of a branching system that form a network. There are 4 types of vascular connections. Arterial-venous and venous-arterial connect down in the cotyledon capillary network. Arterioarterial and veno-venous connect exclusively on the surface of the placenta. There are usually vascular connections found in most all monochorionic twins. It's when there is an imbalance that twin-to-twin transfusion syndrome results. What happens with this vascular imbalance is likely hypovolemia in one twin called the donor twin and hypervolemia in the other called the recipient twin. These compensations can lead to developmental abnormalities. There are increased dangers in the event that one twin dies due to the connecting vessels, because the fate of one twin remains linked to the other through anastomosis. The donor twin develops complications from hypovolemia such as malnutrition with severe growth restriction, redistribution of blood flow, decreased renal perfusion, and malformations due to decreased amounts of amniotic fluid called oligohydramnios. When growth restriction is severe, the donor is very fragile and frequently cannot cope with the added stress of prematurity. Due to hypervolemia, the recipient twin is at risk of cardiovascular volume overload. This overload may cause the heart muscles to thicken, and eventually heart failure may develop that may last into the newborn's life. Suppression of the antidiuretic hormone of the recipient twin causes an increased urine output, resulting in polyhydramnios. The risks to the mother are both physical and emotional. Physical risks are from an overdistended uterus, from increased amniotic fluid of the recipient twin, treatment attempts that require surgery, and from delivery itself. Emotionally, the loss of a wanted pregnancy is very serious for the family. The single most important fact that needs to be determined early in a twin pregnancy is whether the twins are monochorionic or dichorionic. If monochorionic twins are diagnosed, then ultrasound scans should be performed at regular intervals in an attempt to determine whether or not twin-to-twin transfusion syndrome is likely to develop.
Twin-to-twin transfusion syndrome usually presents at 18 to 26 weeks. In the past, weight discrepancy and hemoglobin differences were used for a diagnosis. However, these are late signs. The proposed findings are suggestive of the diagnosis, though all criteria must not be present. Monochronicity, same-sex twins, discrepancy in amniotic fluid between sacs with one twin having polyhydramnios and the other twin having oligohydramnios, umbilical cord size discrepancy, cardiac dysfunction in the recipient twin with hydramnios, abnormal Doppler velocimetry, and significant growth discordance. Twin-to-twin transfusion syndrome is staged using Quintero criteria. Stage 1 is discordant amniotic fluid volumes, but with urine still visible sonographically within the donor twin's bladder. And stage 2 is criteria of 1, but the urine is not visible within the donor twin's bladder. Stage 3 includes the criteria of the second stage, but has abnormal Doppler studies. Stage 4 has ascites, or frank hydrops, in either twin. Stage 5 has a demise of either fetus. Once staging is diagnosed, treatment options can then be determined. Treatment options include expectant management, but the gold standard is laser ablation of the vascular anastomosis for stages 2 through 4. A fetoscope is introduced to the amniotic cavity of the recipient twin under ultrasound guidance, and a laser is used to ablate the anastomosis. Risks include rupture of membranes, abruption, bleeding, choreo, and amniotic band syndrome. Amnioreduction can be used by removing excessive fluid around the polyhydramnionic twin. Amnioreduction improves maternal comfort and improves uteroplacental placental blood flow. Complications can be rupture of membranes, miscarriage, preterm delivery, and choreo. The survival with serial amnioreductions have ranged from 37 to 83%. Septostomy is the intentional perforation of the intertwin membrane to equilibrate the amniotic fluid volume and pressure. This is most useful in prolonging pregnancy for patients who have already reached 26 weeks. The benefit is patients rarely require more than one procedure, though it often requires more expertise. The least preferred method of treatment is selective feticide of one twin. This is sometimes used if there is a life-threatening anomaly in one of the fetuses after a failed laser ablation. Ultrasound-guided cord coagulation can be used with a survival rate of 77 to 88% of the remaining twin. Twin-to-twin transfusion syndrome is a common yet misunderstood disease. Many pregnancies are affected with the loss of at least one baby or have long-term neurologic morbidities. Fortunately, with modern treatment modalities, the overall perinatal survival rates have improved from around 20% to 60 to 70%.
The diagnosis of twin-to-twin transfusion syndrome contributes to a very confusing and stressful time for parents and families. The family will need support throughout the entire process, not just during the diagnosis, but throughout treatment, follow-up, delivery, as well as infancy. Information and support can be found through a number of online groups and organizations.